Perfect. And you can go ahead and send that to me after the meeting. So again, we're recording now. Good morning, everyone. As I was just mentioning, this webinar is a component of the Home Visiting Coordination Initiative, which is a forum for collaboration and conversation. And we love to offer these monthly webinars as an opportunity for learning and conversation. So a couple of housekeeping items. Please remember to keep yourselves muted, just so we can keep the focus on the presenter. There are closed captioning services, which I will enable as soon as I finish with my remarks. You can navigate to the bottom of your screen and click CC, and they should generate automatically. Please, we encourage you to stick questions and comments and anything else you'd like to share in the chat box. We'll be monitoring that throughout the session. This survey, or final remark, this project is a component of the Preschool Development Birth Through 5 grant. So there will be a survey as a component of that grant. We collect data collection. So I'll be sending an email out with follow-up resources and materials, as well as a link to a survey, which will help us continue offering these monthly webinars as well. So without further ado, I'm pleased to introduce Kimberly Seals-Allers. Kimberly is a leading voice on African-American motherhood. She is an author, an award-winning journalist, a consultant, and a public speaker. And her work is rooted in her commitment to reducing the high infant and maternal mortality rates and birth equity. And she's here to speak to us today about her work, as well as the Irth App, as in birth without the bias. And I am incredibly excited to learn about not only the data, but just the inner workings of this app, as well as the inner workings of Kimberly's work. So we're so pleased that you've joined us today. And without further ado, I will hand it over to you, Kimberly. Thank you.
Thank you so much for having me, and good morning, everyone. Appreciate you jumping on and participating in this conversation. I'm so excited when I get to speak to folks in my home state, coming to you this morning from Queens, New York, where I am a proud resident. I like to let folks know I'm a real New Yorker, born and raised in Queens. Went to undergrad at NYU and Columbia University for graduate school. So like I said, I'm a real New Yorker. And so get real excited about connecting with folks who are working in our great city and our state around birth equity and justice, and how we can really address what's going on, particularly with Black and Brown women and birthing people. And how we can change this experience to something that's more joyful, which is what everyone deserves. And so I appreciate the introduction, let you know that I come to this work as a journalist, and that, really started using the power of storytelling to address what I was learning through my own experience when I became a mom. And so really wanting to center that lived experience, and really everything that I started doing was from my own lived experience, and that has always been one of my driving principles. And so I created Narrative Nation as a nonprofit to create narrative-centered media technology as a way to address racial disparities in maternal infant health. And that includes our two projects, the Irth App and the Birthright podcast, where I share positive Black birth stories, which is funded by the California Healthcare Foundation and the Commonwealth Fund. So super excited about the work that we're doing to really use many tools in terms of how we can address this issue. So I'm grateful for you all for your interest in some of the other ways that we could be thinking about this beyond some of the clinical work and other things going on. So we know that bias in maternity care is pervasive, and we know that unfortunately it is deadly. Every year, the Listening to Mothers report says the same thing, that Black and Hispanic mothers have high perceptions of poor treatment due to their race, ethnicity, cultural background, or language. We know what the CDC says around Black women being 243% more likely to die. And we know that right here in our own city and state, that here in New York City, the Black maternal mortality rate is up to 12 times that of white women, right? And so even in our great city and state, we are still seeing disparities that I think we can all agree are unconscionable and a disgrace and need to be addressed. And so that really calls upon us to think differently, right? And so one of the things that I'm excited about is the ways that the media has been giving attention to this issue. Yes, we know that there's now a new conversation. When I first started writing about this, my very first book on pregnancy and childbirth for Black women came out back in 2006, where there was a very minimal conversation about the ways that pregnancy and motherhood were different for Black women, a very minimal conversation around racism and what that looks like. But now we're having these conversations out loud, and now it's time to turn that into action. We learned most recently that even during the pandemic, maternal deaths rose, and that those rose disproportionately among Black women, right? Black women are 1/3 of the pregnant women and new mothers who died in 2020 were Black, even though Black Americans make up over 13% of the population, right? So over-indexed in these maternal deaths during the pandemic, in this new report from the National Center for Health Statistics, and then really wanting to center what we know, that even for women 40 and over, it was higher than that for women who are younger, right? And so again, what's going on with Hispanic women and Black women was only exacerbated by the pandemic. And then when we think about the stories that we hear of, we know that when we think about Serena Williams, this is not a low-income woman's story. It has been very easy to problematize Black women, blame this on lack of access or prenatal care or overweight, or they don't eat well, so many reasons, right? But when we know that the data has proven that even when you remove all of those factors, Black women are still disproportionately dying. It is not a low-income woman's issue. We are seeing women across socioeconomics. Last year, a doctor died. Serena Williams nearly died. All of these women were college-educated folks. And so we need to be clear about what's driving this. Now, we know that this issue of bias has been well documented in every academic journal, right? So for me, that's not the conversation we're having today, right? This issue of bias has been documented, so I don't spend a lot of time talking about it. What I'm here to talk about are solutions, noting that one landmark study found providers giving different treatment options for hypothetical Black patients than they did for hypothetical white patients presenting with the same symptoms, right? And so again, there is something about the anti-Black nature of this racism that is contributing to what we're facing. And so we need to just name that so we can understand it. And then this article also just last month, the New York Times, showing that Black women, Black people were more likely to be described as uncooperative, right? Having this negative language assigned to them, having more of this derogatory language, being called non-compliant, non-coherent, non-adherent, all of these problematic behaviors. Why, right? People labeling folks, but never understanding what is their lived experience, what is their experience of receiving care that might make them non-compliant, right? Love this quote. In medicine, we tend to label people in derogatory ways when we don't truly see them, when we don't know them or understand them. The process of labeling provides a convenient shortcut that leads some physicians to blame the patient for their illnesses. Pure laziness, right? It's right. Not being willing to see people, to know them and to understand them beyond a stereotype, beyond a study, but to really understand who they are with experience. And that's what we're here to talk about. I love this quote from that article where one of the doctors said, we have to educate our providers on listening to patients. Her father, who was a doctor himself, said, if you want to know what's wrong with the patient, ask them and they'll tell you, but you've got to listen to them. And then she acknowledges that in general, pregnant women's complaints are often dismissed, and that is probably much more significant for Black and brown women, right? And we know that to be true. So when we think about all the things that we can do, we have to also understand that even though I'm here to talk to you about technology platforms, some technology has been biased. Algorithms can be biased, and so who's creating it? Who's being centered in its design? Who's been at the table for its development is also an incredible piece of how we are building the right tools to address what's going on. And so when we look at this connection between birth outcomes, breastfeeding rates, knowing that Black women are still disproportionately having lower breastfeeding rates, and Black infants are having higher infant mortality rates. We cannot decouple this, right? These are all connected. And we can't take away from the fact that the people who were breastfeeding the most before they were enslaved are now breastfeeding the least. Their babies are dying the most, and they themselves are now dying the most, right? That cannot be lost on any of us. And so when Dr. Joy Perry kept reminding us that it's racism, not race, that we really have to understand that. And that not just racism as we think of it, but also historic racism, systemic racism, and all the ways that this shows up. And I want to be clear, because I think right now, people think of racism as epithets and tiki torches and using slurs. That's not what we're talking about, right? And we're going to look at some of the nuances, even when I show you some of the Earth reviews, but we're not talking about that. We're talking about this very nuanced way of dealing with people, going back to the comments around making that derogatory language on the comments. I love this definition by Dr. Kamara Jones, who says racism is a system of structuring opportunity and assigning value, right? Whose opinions are valued, whose decisions about their bodies are valued, whose decisions about their children and their ability to say, no, I don't want that shot for my baby. No, I want to do this. Whose decisions are valued and who is penalized or even criminalized for those decisions that they actually have the right to make, right? This is racism, this idea of assigning value based on how one looks. And in many cases, that leads to other assumptions around their family size, if they're married, how many children they have. It's all about trying to make a value judgment. And this is where we fall into a terrible and dangerous practice. We also have to acknowledge the historical trauma of the medical field, right? Knowing that historically, Black people have been used as experiments. And we're seeing this earned mistrust of the medical system playing out on all sorts of ways during the pandemic, right? But we can't forget that this exists, and it exists for a reason, right? It exists due to historical events that actually really happened. And we can even get into Dr. Marion Sims and the ways that the OBGYN field was created. So again, when you see people distrusting, you can't just ignore it, right? That is what we have to deal with so we can create a new movement going forward. That includes the trauma of birth and breastfeeding. Talked a little bit about what happened to Black women during enslavement, when they were enslaved. And so they were stopped from breastfeeding their own babies, a mother's first job to feed her child, right? Often to the detriment of their children. And often they had no power, no ability to be in control of that, right? And none of us can really understand what that feels like, none of us. But this trauma, this interrupted motherhood experience still has generational effects today across the board. And so when we think about all this history, all this trauma, the layers of it, right? Not to become burdened or feel overwhelmed, but one, just to sit into the complex nature of what we're dealing with, and to also understand that we can't just ignore the past. Yes, we want to move forward, but we have to acknowledge what got us here in order to do that, right? And so when we look at people like, why don't you do this? Why don't you do that? Without acknowledging that history, then we're really doing a great disservice. This includes the ways that the media has stereotyped Black women, the ways that we have been portrayed as perfectly desirable for taking care of other people's children, but somehow viewed as incapable of taking care of our own, right? A lie that the media created really to devalue Black motherhood. And I think it's important to note that at one point, our bodies, our children had economic value, right? They could be sold, we could be sold, our wombs could produce additional laborers for the system. But the minute our children lost economic value, right? Our bodies lost economic value to the system, then we became valueless, right? You can see historically that campaign to systematically devalue, dismiss, and denigrate Black mothers and Black children who used to be of economic value, right? So we really can't think about how we got here without understanding these very complex issues, not oversimplifying it. And so when we think about going forward, I love this quote from Dr. Neil Shaw, who's now at Maven, but he said, it's not for providers to expect communities of color to be more trusting. We have to become more trustworthy, right? There's a great, hey, they should do this, always putting it on the patient, always putting it on the people who are being most harmed by the system. But what are we doing to develop a trust creation process? If we truly acknowledge a history and we understand that much harm has been done, we need a new strategy that allows us to build trust, and knowing that trust is a critical component of equity. We can't have equity without trust, and we won't have equity without transparency. And so these are the things that we have to really consider, because if we think of equity only as clinical outcomes and counting numbers, that hasn't worked, right? And so let's talk about some other things that haven't worked. We have been trying a number of solutions. Yes, to evidence-based maternity care, very, very important. But I've been asking for many years, evidence-based on whom? Because the fact of the matter is, much of the evidence base that was used for years to determine maternity care was not rooted in Black people or brown people at all. Excluded women of color across the board. If you look at breastfeeding research, excluded working people, just an evidence base that was based on very few people with a hope that it would work on everybody. Unfortunately, that hasn't worked out. So how do we build a new evidence base that actually centers those who have been disproportionately harmed by this system, those who are disproportionately dying and nearly dying, right? We need a new evidence base, and we can't build on the same one because, quite frankly, it hasn't worked. And that's okay, but we have to try something new. We know there are anti-bias trainings, really, really important. Unfortunately, they've become a tick the box exercise for far too many. I'm not convinced that you can train away bias. It's something that we all swim in. I have my own, I'm sure. I took the test, so I know that I do. And there's been a lack of accountability. Nobody ever checks in to see whether that training actually improved the patient experience. It's just assumed. That's weird for a medical field that measures everything. But this, for some reason, is not measured. Then maternal mortality review boards, an important contribution. But why does death have to be the trigger for analysis? Why do one of my sisters have to die for someone to stop to analyze the care? That doesn't make sense to me, right? And so at Irth, we say, let's learn from the living. We can learn from the living. We can use digital platforms to crowdsource experiences and then learn how to improve to prevent an adverse event, to prevent another death or near death. That for us is a much better approach. And so we center this approach with this very foundational premise, right? Whatever the question, the answer's in the community, right? Whatever the question, the answers in the community. This is such a powerful statement because much, in our work, it's the answers in the medical journals, the answers in the data. Okay, but what kind? Answers in the research. But what if the answers in the community? And so when we think about the community has been a place that's been viewed as some place that people with lots of degrees and consider themselves to be much smarter go to fix and change. They have a great idea. Maybe they ask the community to help them execute it. But the community is actually the source of solutions, and they deserve to be centered fully in anything that we're doing to achieve equity, anything that we're doing. And I mean at the table from ideation. There's an expression right now, if you haven't seen it or anywhere, I suggest that you please write it down. Nothing for us without us. Nothing for us without us. So if you've been thinking about doing something for us, and I'm speaking as a Black person, but you haven't included us from ideation, please don't do that, right? Nothing for us without us. And so too many times the people who really are carrying the burden are the last to be considered in an attempt to help and save, and that hasn't worked either. So how do we try to do something different? I often say the experience of being interpreted is different from the experience of being understood. So many people, for years I've been doing this work. Oh, Kimberly, I read this study about Black women in this. I read this study about Black women in breastfeeding and why they don't breastfeeding and why they don't nurture and all. That's an interpretation, right? What we're going for is an understanding. And to understand people, you got to talk to them, right? You have to hear from them in their own words, because anything else is an interpretation. And so how do we move from this idea of trying to interpret Black people to a way to understand them, right? In a much deeper way than perhaps the 4 or 5 or 10 person focus group that perhaps is being held once a year or however often. How do we have a deep understanding? So we created Irth really with these thoughts in mind, right? As was mentioned, Irth is like the word birth, but we dropped the B for bias, so it's IRTH. And it is really centered on being a digital platform that is designed to address racism and bias in maternity care, because it is a root cause of the Black maternal mortality crisis. And if we don't begin to talk about it, collect data on that, and assume and recognize that the training, we have to be beyond the trainings, that we're not going to get there. So Irth is a review and recommendation platform and data aggregator for Black and brown women and birthing people to find and leave reviews of their OBGYNs, birthing hospitals, and pediatricians, right? We are all about centering those who are being most burdened. Folks can leave reviews of their prenatal appointments. That's our great sweet spot. Come back, leave a review of all your prenatal appointments. Come back, tell us about your birthing experience. Come back, tell us about your postpartum visit, and come back and tell us about your pediatric appointments for baby up to first birthday, right? Really trying to capture that perinatal spectrum. One of my dream data projects for Irth is when we have captured the experiences, right? Because right now we're building the first ever national repository of experiences of care for Black and brown folks in this unique perinatal period. What can we learn about how people interact with healthcare beyond that, right? We know this is a critical time. We know this is a vulnerable time. So much we can learn, right? And so I'm excited about all the opportunities that are possible when we actually center the communities being most harmed. On the app, you can also search reviews by hospital, doctor, zip code. And so we are driving accountability and transparency. Sorry, that's supposed to do something. There we go. We are driving community accountability and transparency and giving the community a resource, right? People are always saying, what can you do to have an empowered experience? But your community is also a resource. We encourage folks to leave their reviews. Let's inform and protect each other. Now, we are here to drive accountability. We are here to drive transparency. And we are here to create a tool for Black and brown folks to inform and protect each other. On the back end, we turn those reviews into data. We turn these qualitative reviews into quantitative data to work directly with hospitals, payers, providers to help them learn from the living. This is the work that we do on the back end, right? We understand that people are not being treated the same way, but we also understand that most hospitals and healthcare systems do not have up-to-date Black patient experience data, particularly as it relates to maternity and infant care, right? And so how do we actually create more equitable care? By learning from the lived experience of Black and brown folks, looking for those trends, identifying patterns, identifying gaps, and then offering the solutions to address those gaps. That is the work that we do. You can leave a review as a birthing person. So we accept reviews from mothers and birthing folks, as well as fathers can leave a review, and doulas, as well as hospital-based midwives. And so really, again, understanding what this new evidence base needs to include. Really appreciate the doula reviews because doulas see a number of births. And so when we go back to hospitals and providers, not in addition to our patient reviews, we share what doulas have seen because many times they have seen multiple births at that institution. And so their context can be even deeper. Plus they see those distinctions in their clients, whether that's along racial or ethnic lines, class lines, insurance lines. So doulas have just been our critical piece of this new evidence base that we're building to transform the health system. And so one of the things that we also seek to do, as you see here, is to really understand what bias means. One of my concerns when I was kind of ideating over Irth was that hospitals and providers would, they would take the training, they think that they're nailing it, and the patient is having a completely different experience. Because we've been talking about bias and even disrespect and all these words in a very abstract notion, because what's disrespectful to me may not be disrespectful to you and vice versa. And so now how do we get to the details? So this is one of the screens where we ask a lot about positive behaviors, but we also ask about what we call our negative practice behaviors, right? Were you yelled at? Was treatment withheld? Were your requests for help ignored or refused? Did you actually experience rude comments? Something as nuanced as lack of eye contact. Let's get these details together. So now when we go to a hospital, we get to say, hey, we have 600 reviews or more, right? 200 people said they were yelled at. 100 said they felt treatment was withheld. This many people said that physical privacy was violated. We give them the details. There is no ambiguity anymore. We can tell you when it happened, how often it happened. And again, we're looking for patterns, right? Not one-offs. We look for patterns. That is the work that we do with our data team on the back end. But this is what we have to do. We have to get to the details of the experiences so we can address the specific behaviors that actually feel harmful, not to us, but to the people involved. And so our goal on the front end, we're giving our users these crowdsourced peer reviews because their community is a trusted resource. This is how we have been getting referrals for years. We are very clear that we need to activate consumers, right? Not as victims, but as powerful consumers. I let folks know I was a senior editor at Essence Magazine for many years. And when you're in management at Essence Magazine, you know very clearly how much people want to market to Black women as a powerful consumer block. How do we activate Black women, not as victims of this crisis, but as the powerful people that they are, who actually have a tool to address this? And that tool is their experiences. That tool is their story. We put it on a technology platform. We drive transparency, accountability, and now we are putting the power back in the hands of the people and addressing some of these systemic imbalances that have caused us to get here. And we center those most burdened by the issue. Then on the back end, we turn these qualitative experience into strategies, into actionable steps. And then how do we use Irth as an early warning detection system? So we're actually preventing harm by recognizing harmful patterns before they be turned into an adverse event. And then we want to give hyperlocal data. I let everybody know that racism in New York City is not like racism in Birmingham, Alabama. I've worked both places, right? And so we don't need a one size fits all approach to a problem of this severity and urgency. And so we can give you what's happening in your city, in your facility, in your state. This is what we want to provide. Ultimately, we will be using this to create the training and credentials that we want every community to take advantage of, excuse me, with an idea that everyone is accountable to the communities that they serve. That is the ultimate accountability. So in our reviews, excuse me, when you go through the birthing review, you're going to be asked about the doctors, nurses, and lactation consultants. Breastfeeding is a big, important part of my work, if someone doesn't know that about me, and learning about these in-hospital experiences around lactation are also important. So again, when we look at these reviews, what can we learn, right? Many times we see comments and reviews around the staff, people feeling safe because they see other people look like them, or unsafe because they do not. So how do we reflect that back to the hospitals around what that means? I ask a lot of hospitals, what does patient safety mean to a Black birthing person? And no one has been able to really answer that for me. But how do we think about all the QI work, all the quality improvement stuff that needs to happen at hospitals, but they don't have Black patient experience data, robust data to use to inform that? It's deeply troubling. And then here's, they did not listen to my pain levels. Again, when we see that in frequency, because we know that every Black maternal death story has this thread. Someone's pain levels were ignored. And so if we see this happening a lot, how can that be a part of our early warning detection system? We also see a lot of comments around pressure, people feeling pressured to do things. Again, that valuing who said, no, I don't want this from my baby, whose decision is valued, whose decision is questioned and criticized. Lots of comments about residents. That's a whole nother presentation. I love this review over here because this mama ended up in the NICU, right? Which we can all agree is not anybody's ideal outcome. But she left such a positive review about the NICU staff, right? And this is what we see over and over in our Earth reviews. People can make a distinction about what happened versus how it happened. Everyone can understand that you ended up having a C-section. Maybe your baby ended up in the NICU, all types of things. You can accept that. But how it happened, if no one answered your questions, if you felt disrespected, if you felt coerced, that will cause you trauma, right? And again, we're counting deaths only as if the whole spectrum of trauma doesn't count. It does count and it does matter. And we have to capture that and try to address that too, right? And so how do we not just think about what happened as in you didn't die, so this is a good outcome versus how it happened, which is everybody deserves a 5-star experience or as close to it as we can get, right? Too many Earth reviews when we ask, what's the best thing that happened to you? Too many people put, I'm alive and my baby is alive. So not okay. So not okay. We also see a lot of comments around lactation consultants, comments around pediatricians, around breastfeeding. I love the reviews where people actually know stuff and they're like, why didn't they talk to me about colostrum? Which is a question that we ask as well. So again, capturing this, understanding what's important, being able to use these qualitative reviews as a form of data for others is really what we're doing. Right here in New York City, right now, the #1 negative experience being reported in Earth for New York City is my request for help were ignored or refused. You can see #2 is physical privacy violated, and then being scolded, yelled at, or threatened, condescending or rude comments, forced to step on one treatment. On a national level, this is #1, request for help were ignored or refused. #2 is I was scolded, yelled at, or threatened. #3 is dismissiveness of pain levels. #4 is physical privacy violated. And #5 is experiencing condescending tone or rude comments. So again, really, really important. Too many reviews around people being judged around their family size, people in active labor feel like they're being coerced into birth control, not the time, people being asked about, validating their marriages, all sorts of things, and have nothing to do with your care, nothing to do with your care. So we're excited about the momentum that we're building that centers the communities most burdened. We were mentioned in the White House Maternal Health Day of Action press release because of our partnership with the March of Dimes. The March of Dimes is doing their own maternal care initiative, their own interventions in hospitals, but they will be using Earth as part of their evaluation tool, right? How do we go in, capture a good feedback of community sentiment? They will do their intervention, and then we will be coming in behind as a part of evaluation, right? Again, so many possibilities and use cases for Earth that I'm excited about. And so it's not just about what we're doing with hospitals, any initiative, anything that claims to want to achieve birth equity needs to have a robust mechanism for capturing community feedback, or else how is that going to work, right? If there is no accountability, there will be no equity. And if there is no transparency, there will not be equity. And so what are we doing to get robust community feedback? Not about centering hospitals. I have to say that it's been deeply disturbing to me, the number of birth equity initiatives that I speak to who ask me to de-identify hospitals in presentations or express concern about hospital feelings. Literally, someone said, we don't want to hurt the hospital's feelings. Do hospitals have feelings? Anyone? Okay, I thought it was just me, because we have literally humanized an institution, but we have dehumanized real people. But hospitals have been centered for far too long. And if we don't address that and bring other tools into this ecosystem, right? Hospital work is critically important, but it can't be the only thing, because we've been asking hospitals to do better. We've been asking hospitals to do better for a very long time. Now, as an outsider, a business journalist by trade, a consumer, a mother, I have seen the power of ratings and reviews move other industries. Maybe you have seen that too, right? And so could public ratings and reviews be a driver, not the only thing, for birth equity? for our city, our state, and nationwide? That is the question we seek to answer every day, right? Let's see. For me, it's a time for innovation. It's a time for trying all the things. And it's a time to actually center the people instead of the institutions. And so our goal is to figure out what makes a 5-star experience for Black birthing people. That's really what we want to figure out, right? Let's analyze it. Let's discover what that looks and feels like. When we do our analysis, and this is literally a data dump from the state of Louisiana, we always start with the 5-star reviews to understand what made that so for that individual, right? How are we actually learning when things go well, not just from when things have not gone well, so that we can create that goal. And then to always center that you can't change what you can't see. It's real simple. If we're not willing to see it, then we're not going to be able to address it, right? And if we're not willing to measure it, then we're not going to know how we're doing. And so through our hospital pilots, we provide the in-depth community feedback by doing the review collection. We analyze the reviews, we learn what's going well, what needs to improve. We create the strategic recommendations, and then we implement them. It's really quite simple. We help hospitals create an improvement plan, but this plan is completely centered on what the community says is important to them. And then we allow the hospital to implement, and then we go back in to assess again, right? We do another round of reviews, really trying to think about having this continuous, ongoing feedback from the community as the way forward. We currently have a hospital pilot in Detroit. We just completed our MOU for a hospital in Los Angeles, and we're about to bring on a hospital in Philadelphia. And we're really excited about the collaborative in the state of Louisiana that is also working on a designation that needs a more robust feedback for community input. So we're excited about all of these opportunities, and I'm looking to develop more right here in my home state, where we know there's a lot of energy, activity, and where we know there is need. My vision for Irth is that it does become our good housekeeping seal of approval, right? That doctors and hospitals will want to be Irth approved, and that this is something that they can aspire to. I'm looking for the first Irth approved, to make the first Irth approved hospital for our city and state as something that people would want to do, something that says, wow, we have been vouched for by the community. That is the most valuable symbol you need to have on your website, right? And then we become this beacon for our community to be looking for that, and knowing that is a place where other people who look like me have said they feel safe, that they have felt seen, that they receive good care. How do we do that? Our goal as an organization, we're looking to expand our hospital and our insurance pilots. We think payers are a critical piece in this ecosystem for getting them to pay attention to Irth review. So those types of relationships are important to us. We're talking to a few here in New York City. And then how do we use Irth data to not just work with specific hospitals, but find what's working that we could share with the field? What are the best practice models? When we see hospitals that are consistently getting Irth reviews, good reviews, what's going on there? And how can that be replicated that we could share with the field? And so much is possible if we can center this lived experience, and then thinking about Irth as a tracking and accountability mechanism, whether that's around anti-bias trainings that are happening, whether that's about other processes, right? And so for me, it's about Irth being provided to hospitals either desiring to be Irth approved because they've seen that it matters to the community, or they are being required to be Irth approved because we've embedded ourselves in the systems that ask folks to do things, right? The regulatory systems, the health departments, et cetera, et cetera. So super excited about this potential. Our goal is to build an ecosystem for equity, but it must be centered in the lived experience. We cannot just focus on clinical outcomes. We cannot just focus on hospitals. We cannot think that we can move them through training alone. We have to center the community, empower them, use them, leverage their power as a tool for us to move all of these things. And then building in accountability and transparency to get more respectful and equitable care. And so I'm here because I need your support, right? We are looking to, one, expand our database of Irth reviews in New York City and New York State. Can you help us spread the word on social media? When I finish, I will put the link to our social media toolkit in the chat if Maggie or Jen don't already have it to share. We would love for you to help spread the word and help us activate your community to share their experiences. Is there a New York State pilot project, right? Is there a hospital out there in our state that could be a great target for learning about the community and benefiting from our data, which has become so rich. We have recently received a grant from the New York State Health Foundation. So we are actively seeking a pilot partner, hospital pilot partner in New York City and in Rochester as part of this grant funded work. So this is a no cost pilot that the New York Health Foundation, I think they just changed their name yesterday, has given us a grant to fund. And so I would love just to pause right here before I close, just to, take a moment to hear any feedback and ideas. I will also turn my attention to the chat now, see if I can answer any questions.
If it's helpful, Kimberly, I can read out loud. I'm not sure if you can see the chat while you screen share.
Yeah. I'll go up and see if I've missed anything. If I miss anything, let me know. I'm going to start with, would love to hear how the data that you have provided back to hospitals has shifted how they approach their work. Well, thank you so much for that question, Michelle. And so our Detroit pilot is the one that's furthest along. And so we are in our analysis phase right now, and we will be sharing that back to them. But we have seen, sometimes it is big things, sometimes it is small things. And many of our data runs, we do see providers who are repeat, as we would call them, offenders, right? And so there's been a lot of conversation about more empathy work being necessary. For some, there are some real specific trainings that needs to happen. I think that for the most important thing has been, many of these hospitals really think that they're doing awesome and didn't know how their community really viewed them. And so I think, just having their eyes open to the realities and that disconnect of the experience that they think is going on versus what their community is saying has been a very eye-opening approach for them. And I always applaud them for having the cultural humility to listen, right? I mean, anyone who's in our pilot is because they're willing to listen to their community. And so I think that that has been the most important shift. One is the realization that they need to have more work to do, which is all of us, right? And then learning what that could look like and hearing the details about what specifically needs to happen for their patients to feel respected and whole and complete when they walk out the door. And so we're excited that as we get deeper into our work with our pilots and the new ones coming on board, that we'll have more to share about that. Medical school and training. Yeah, we've been working. So lots of medical schools and training folks have definitely reached out, and we're very excited about bringing this in. Residents are often mentioned in the Earth reviews. So there's a lot of training opportunities there. And we know that part of that is cultural, right? It's like they're just adapting a culture. And so our goal is that if we can create a different culture in the hospital system, regardless of, and then kind of introduce this culture in medical schools, now people are going to be met with a different approach. But always interested in how we can bring this perspective to more folks early on in their medical journey. I think that is critical. How does a community push the hospital systems to pilot with Earth? That is a great question. Usually the way that happens, and I'm sorry, someone is coming on there. Loud car, so I will get rid of my breeze. Can everyone hear me okay? Usually how that happens is, we activate the community to capture reviews. So I would love to say that we get pilots primarily because we went to a hospital and they were so excited about this opportunity. But often what happens is we already have reviews of them. As you know, Earth is public. It's available in the Google Play and Apple App Store. And so we often have reviews. We've activated the community first, right? When the community knows that there is a need, we've activated the community first using doulas, birth workers, organizations like yours, home visiting folks, getting the reviews first, we analyze them and then we present, right? And so that is often how we get hospital engagement. It is by activating the community, getting the reviews, we analyze those reviews, and then we present it. And that is often what we can do. From PowerPoint to gallery view. Okay. I don't know how to do that, but I will come back to that. Great to hear. Rochester,
Oh, sorry,
Would you
completely.
share?
I think they're just asking if you stop screen share so we can see everybody's faces.
Oh, okay. I wanted to just do my last actual slide and we'll go back. I want to make sure I
Okay.
have more contact information. One, I always close by talking about collaboration, right? That this important way that we need to start thinking about equity, which is not about helping or saving folks, but it is about a unique understanding that our lives are inextricably linked, right? And that the work that we are doing is not for others, it is truly for ourselves, because ultimately you're not going to be free if I'm not free, and I'm not going to be free if you're not free, and that none of us are free until all of us are free, right? And so that is why we do this work, is an understanding of that, right? And so I just want to share my contact information, which I can also pop in the chat, and then go to, I will stop the share so we can all see each other and talk some more. Stop share. Okay, great. So yeah, would love to hear some ideas on, what, Michelle, I'm not going to share who we're working with in Rochester just yet. But I'm excited that we have them at the table. And I look forward to updating folks soon. Yeah, so would love just to, hear any thoughts on any suggestions on how we might be able to increase engagement, any feedback about what you're seeing in your own communities that may be helpful, and, leave it a little bit open. Oh, can you speak more to the relative advantage of this external center? Yes, very happy to talk about that. Thank you, Claire, because if one more person mentions Press Ganey to me, my head may explode. First of all, because of that, one, the earned mistrust that we spoke of, hospital administered surveys are just not getting feedback, right? Even the HCAPs, and hospitals do admit this to me all the time, right? We have hospitals that have high percentage of Black and brown folks birthing there, but they are not getting these responses because, first of all, you don't trust that institution. You don't know where it's going. You never know whether that's information going to be helpful. It just goes into, I don't even know where it goes, right? Having completed them myself and feeling like this was a waste of my time. And so two things that happen. When people leave an Earth review, and I want to share that our reviews are moderated by a panel. All reviews have to be read and approved before they are entered into the database, and that all our reviews are anonymized, right? And so people verify themselves the way you would in many other apps, but once those reviews are put into public, they are anonymized. So our reviews are anonymous. But people know that their review is of value to their community immediately, right? And so that is something that there is no hospital survey that could ever provides that. Nobody is asking questions about perceptions of racism and bias. And what we found because of this lack of trust is like having an independent, community-centered, Black woman-led tool is actually more advantageous. It is considered to be a key part of how you can rebuild trust in the community, not just by asking you your own questions, by saying, here, share it with your community and we'll get it from there. And so I think this is a really important distinction, one that I spent a lot of time trying to explain to hospitals. Many hospitals who love Earth, but are so afraid of the transparency, that is when they all run away. And that is something that we do not negotiate about, right? The data does not belong to them. It ultimately belongs to the community. And regardless of how we may moderate or hold reviews for a short period of time for whatever we're doing, the reviews ultimately belong to the community. And so these are important distinctions that we need to kind of raise a bit more clearer. And I see a hand from, is that Vidya?
Yeah.
Okay.
Hi.
Hi.
My brain is exploding and I feel like I'm shaking a little bit, but there are a whole lot of ideas that I had while you were talking. One being that I'm part of the childcare side. So I'm like part of the other side of birth, maternal, infant, early childhood home visiting program. And we are trying to re-inform and redesign our program with like a community-centered approach where we're capturing narratives and we're capturing voices and we're capturing their vision for how they want to raise their children. And I think there's an opportunity there to increase the level of participation on the app, because it's post-maternal birth and it's a little bit after. It's like 16 months in, where I do think maternal birthing experiences are so traumatizing that it takes like 2 years to even understand what happened.
Yeah. I agree.
Yeah. And there's there's obviously an invested community of pregnant women who are going to want to know this information from members of their community. I was also thinking about how the framework itself can inform the narrative content that informs their program development, if that makes sense.
Okay. Tell me what you mean.
Yeah, I will. So in looking at community-centered development of early childhood programs, the community is essentially developing their own ecosystem of childcare. And they have their own ecosystem of childcare, which is amazing and phenomenal already. It just doesn't get highlighted in the state. And that's usually the kin caregiver, the grandma, the family friend or neighbor, the childcare provider, all typically Black and brown women who are providing childcare to an entire community who are doing it really well, who obviously may or may not need supports and finances. So how do we use that narrative form of data collection, like Narrative Nation, to start the conversation of what Black and brown caregivers actually need in their community to support their community's ecosystem of childcare?
Yeah, that's such a great question. I mean, obviously, we know right now that there's a great need for Earth across the spectrum, right? And so even though we're focused on maternity and infant care right now, we do have a roadmap to expand to other areas, and childcare is certainly one of those areas. I think what we see, and I would say this is a lot around the postpartum and pediatric reviews, and I think I showed you one, was the ways that people's experiences are being shaped by their healthcare interactions, right? And so what is the role of childcare providers, and not to burden them more, but what is the role for more advocacy around these healthcare interactions, right? And so how do you get even the childcare centers to be a part of the consumer force that starts holding these health systems accountable, because the childcare centers are also actively a part of a child's health, right? That is where many of them spend their day. And so I'm really interested, I don't think I have an answer about how we can have childcare centers. Right now, our work with them has been with many of the early Head Starts in different cities where we go, bringing in the parents. To your point, these after birth reviews are the most important time. We do not get a lot of reviews at the hospital. That has not been our most effective touch point, but we have been working on pediatric appointments, childcare centers, when people are coming there. We're actually going to be at one in Detroit on June 9th, getting people when they come drop off their children. So again, how can these childcare centers be activation points for leaving the reviews is something I would be very interested in. And then using that data to create, more knowledge just around what parents need in general. Thank you. Yeah, and if anyone's interested in that, in your area, how can we activate a group of, childcare centers around Earth review collection? I would be very interested. Earth works best in geographic density, right? And so that's why we end up being right now city focused, because if we can get a lot of reviews from one area, then we can, really get richer data. So we're really trying to focus on that. So if there's a cluster in a part of the city or the state that wants to get together to do a coordinated thing that we could try to get a lot of reviews, then we can analyze it, see what folks are saying, and then share back with everyone and see what we learned.
Our program is fairly statewide, and we're in Rochester.
Okay, great.
Yeah.
That'll be great. Rochester is our second focus city for our New York State Health Foundation grants. I would love to hear from you so we can, I can stay in the loop. I will be back up there soon. And then maybe we could see about any potential, opportunities while we're there. I'm going to put the link to our social media toolkit before I forget. I really would be grateful for any support and help just around sharing on your social media platforms, talking about Earth in your newsletters. If you need some more language that beyond what's provided there, please reach out. Would love to talk to Long Island. Thank you, Joy. What part of Long Island are you in? I raised my children in Bayshore.
We cover all of Nassau County, but I have a counterpart in Suffolk County, and our office is in Garden City. But we're doing a lot of work. There are a lot of communities, particularly Roosevelt and Uniondale, Freeport, that I think would be very interested in having this conversation, and that have an abundance of childcare programs. I'm from the Childcare Council of Nassau, and we've been working with Dr. Tots around connecting childcare providers through developmental screenings, and so doing both the hand of childcare, pediatric offices, and developmental screenings. And I think this would be a lovely extension to some of that work. So I would love to have
Yes, that would be so awesome, Joy. I would love to say, I'm gonna make sure I put my email in the chat. Also adding between Northwell Health has been one of our active conversations around a pilot. So I would love to stay connected. We'll see how that goes. But always grateful for the support. I'm gonna put my our project manager is Jennifer. Any suggestions that you have, any ideas, if there are existing events where you can, share about Earth, please reach out. We appreciate the support. Like you all, we're a small team, but mighty and determined. So if you are doing, anything that's going to be out in community, you think it can be an opportunity, even just to have promo cards or things at, your table, please let us know. We'd be happy to get those to you. And we'll be grateful for any of the support on your newsletters, social platforms, text blasts, just let me know what you're thinking. And if there is an opportunity with the childcare centers around, hey, let's get 5 or 6, and we're going to have an Earth Review Day, which is, whether we do it at morning. I mean, I was always crazy at drop off, but pickup seems to be a better time. Where people might be able to have fun. What we're doing in Detroit, we're going to have some, some snacks for moms, and we create a little experience for them. We always give them an incentive because we value people's experiences. And so if there's anything like that we could be doing, particularly in New York City and Rochester, but elsewhere around the state, that would just be awesome. I think we are also really interested in what's going on in Albany, Troy area as well. But thank you so much for hosting me today. I am so grateful for the opportunity to share, and I'm really looking forward to staying connected. And please reach out anytime. Anything else before we close? I want to respect everyone's time. Oh, thank you. I appreciate it. Absolutely. Thank you for the questions, Michelle. I appreciate it.
Robin, were you jumping in quick?
Yeah, I'm sorry. I was trying to raise my hand, but I think I'm having some technical difficulties. I just want to quickly say my head is exploding also. And I have to say it's the third time I've probably heard you present, and every time I come away with so much information, so many ideas, and so much inspiration. And I'm going to have trouble getting it out so quickly. But our program is based in Central Brooklyn. I work with Healthy Start Brooklyn, the Community Action Network. I know you came to speak with us there, and United for Brownsville. We're working with an organization called Wiggle Room that's trying to come up with an app to help families identify early care and education options for their children, and they're with a particular focus on group family daycare. I had suggested, and I hope I didn't break any propriety regulations, but I suggested they take a look at Irth App as well as InsideSchool.org, because the community feedback is so important. And they're shying away from it for any one of a number of reasons, not the least of which is litigation. I wish they were as bold and and as innovative as you, and maybe we could get them there. But that's all to say that we are, we still want the community connection. And so there's going to be this app, but we are going out and meeting with all of the, well, as many of the childcare providers as we can. And in doing so, I will definitely promote Earth and see if we can get a collective group where, as you described.
Yeah, please stay in touch, Robin. Would you email me?
I
And then
absolutely will.
in Brownsville, which I'm very interested in, and in general in Brooklyn, how early are children going to childcare? How young do folks take babies these days?
Well, that's the problem. You know, families have to go back to work, and they can't because they can't identify childcare for children under generally under the age of 3. There are some more options now for between 2 and 3 because some of the Head Start programs have applied for early Head Start, but they're primarily for starting at 2 years old so that they can increase their numbers because now the 3 and 4 year olds are going tend to be going to the public schools where their older siblings attend.
Right.
I keep encouraging them to start younger, but no, you know, but it's hard. It's expensive. It's staff intensive and staffing is an issue. But I think if families had an opportunity, they would send them to childcare earlier, not because they don't want the time to be with their families, but it's, you know, they have to be able to provide for them.
Right.
And I think now it's a trade-off.
We don't have paid leave.
Yeah.
Okay. Well, I really appreciate if you would reach out and
Absolutely.
give me an email. I mean, especially since you're right there in Brooklyn, I would love to get more connected to the Healthy Start there and what's going on and for us to continue this conversation.
And we work with the youngest children. So we work with pregnant parenting families with children, you know, 0 to 2.
Okay, love it, love it, love it. Okay,
Thank
let's
you.
definitely stay in touch. Thank you.
Yeah, thank you very, very much, Kimberly, on behalf of the HVCI, Jen and I know everyone hopped off already, but I will provide the social media toolkit link, as well as your contact information and the project coordinator's contact information in the follow-up email. And this recording is available to registrants of the session. So I will have all that information included in the follow-up. We just can't thank you enough. This is, I know everyone's saying their wheels are spinning, but mine are as well. So I think we're just all excited and jazzed up. So thank you.
Absolutely. Thank you all so much. Enjoy the rest of your day. Look forward to hearing from you all soon.
You too. Thank you.
Bye-bye.
Thank you.
Bye, everyone.
Thank you.